Thank you all very much for coming to my session this morning. And I just want to say again, I've really had the pleasure of meeting a lot of you already, and I've enjoyed thoroughly interacting with all of you. And I also want, this is actually also my first trip here to India, and I also want to just say a special word of thank you for all the warm hospitality that I've had here so far. So it's going to be a hard act for me to follow Dr. Pali's wonderful talk on postpartum hemorrhage, because metabolic syndrome, unfortunately, it's going to be one of those talks where there is going to be a fair bit of epidemiology. But my job is to actually just present all the recent evidence surrounding the syndrome, and actually just to empower you all to kind of take a step back and just take a good look at the patient when they first present to see you, because there are often things that are present that may not kind of immediately meet the eye. So first of all, what is the metabolic syndrome? And you know, I've kind of highlighted the definition here of the metabolic syndrome, and I thought that it would be worthwhile for me just to kind of highlight the points quickly. So basically, you know, the criteria that most of us use is according to the National Cholesterol Education Program, ATP-free criteria, and in essence, it actually, the definition of metabolic syndrome requires any three of the following five traits. So the first one being the presence of abdominal obesity with the waist circumference of being more than 102 centimeters in men and more than 88 centimeters in women. The second one is that of a serum triglyceride level more than 1.7, or anybody who's already on any drug treatment for this. The third one is a serum HDL cholesterol level of less than 1.0 in men or less than 1.3 in women. And again, you know, relating to anybody who may already be on medications for this. Fourthly is the presence of a blood pressure reading of more than 130 on 85 millimeters of mercury, or somebody who's already on drug treatment for this. And last but not least, anybody who has a fasting plasma glucose of more than 5.6 millimoles per liter, or again, who already have diabetes and is already on treatment for this. So this is the most common definition that we use. But an alternative one that we see often in the literature is the one proposed by the IDF, which is the International Diabetes Federation. And this one actually purports to have the increased waist circumference as being one of the criteria that has to be present. And what I like about this criteria is that it actually gives ethnic specific cut points, whereas the previous one kind of was mainly targeted at a Caucasian population. So I guess for the purpose of this audience here, for South Asians, the cut points are a little bit different, which I think is actually more realistic to the population we deal with here, is where the waist circumference is more than 90 centimeters in men or more than 80 centimeters in women. And then plus the presence of any two of the following four criteria, like increased triglycerides, reduced HDL cholesterol, increase in blood pressure, or increase in fasting plasma glucose. So the metabolic syndrome, you know, as we all know, is associated with it being a pro-inflammatory and prothrombotic state. And a number of studies have shown the following associations, that there is an increase in C-reactive protein in these individuals, there's an increase in interleukin-6, increase in plasminogen activator inhibitor 1, and a reduction in reduced in adiponectin levels. So large number of studies have confirmed these associations. So not surprisingly, what are the risk factors for metabolic syndrome? So not surprisingly, the increase in BMI is probably the major risk factor. And the NHS free data reveals that for people who have a BMI of less than 25, the risk of these individuals having metabolic syndrome is about 5%. And for the BMI between 25 to 30, it becomes 22%. And when the BMI actually reaches about 30, it's actually 60%. And certainly in the USA, there's more and more patients these days which are classified as having a BMI of more than 30. And right now, in the group of in the population of patients that I look after, there is at least a 50% rate of women of reproductive age whose BMI is more than 30. So as you can see there, the rate of metabolic syndrome is already, we're looking at 60%, right? And that's in my cohort of patients that I look after. And importantly, it is good to actually be aware of the anthropometric waist circumference measurements in individuals, because the increase in waist circumference alone identifies about half of these individuals who develop metabolic syndrome within 5 years. So what are the consequences of metabolic syndrome? So the obvious ones I've listed here, obviously the development of type 2 diabetes and the development of coronary cardiovascular disease. As you can see, the relative risk factor for type 2 diabetes is between 3.5 to 5.1, depending on the study that we look at. And for cardiovascular disease, the risk factor is between 1.53 to 2.18. And again, it depends on the study we're looking at. So therefore, it's very important for us to identify these individuals early in order to offer them aggressive lifestyle modifications such as weight reduction, increased physical activity, and an improved diet. And in the US, a lot of OBGYNs see patients on an annual basis when they're not necessarily, when they don't necessarily have a problem. Like they actually just come to see the OBGYN, for what they call an annual visit. And one of the things I always do, I always discuss is that whenever patients come to see you for an annual visit, just, even if there's no active issues, just take an active interest in the general lifestyle, because, because like I said, identifying these people with metabolic syndrome early can really go a long way in preventing a lot of complications for them down the track. So what are the other associations of metabolic syndrome that I haven't listed before? So, I've listed the key ones here, like non-alcoholic fatty liver disease is a major one. PCOS, which is something that's very close to all of our hearts. It was first described back in the 1990s that this was had a very strong association of metabolic syndrome. Obstructive sleep apnea is something that's grossly underdiagnosed, but which is present in a large proportion of our community, and it's well regarded that early treatment of obstructive sleep apnea again prevents a lot of the metabolic sequelae that we see, and actually there's emerging data to show that pregnant women with obstructive sleep apnea, if they're to get treatment, diagnosed and get treated early, it goes a long way in preventing a number of the metabolic sequelae that we see in these women. Chronic kidney disease and microbiome, likewise, the NHANES data shows that the odds ratio of chronic kidney disease is 2.6 for people with metabolic syndrome, and people just having microalbuminuria is 1.9. And hyperuricemia and gout is something that we hear of quite often as well. So let's start looking at the actual published data on the sequelae, the pregnancy sequelae of metabolic syndrome. So Chatsi et al. In 2009 published a couple of very, very elegant papers based on the Greek, based on the population in the Crete, which is one of the Greek islands, and this particular paper shows that the relative risk of gestational diabetes in people with pregnant women with metabolic syndrome is actually 3.17. And particularly, there was a very, very strong association of people with impaired fasting glucose. Like if they had a pre-pregnancy impaired fasting glucose, the relative risk was almost up to 5.0, like of them getting GDM, which is hardly surprising. For pre-pregnancy BMI of more than 30, the relative risk of them getting GDM was 2.65. And if they had sort of slightly elevated blood pressures, they also, again, had an elevated relative risk of getting GDM as well. And of note is that for each increase in pre-pregnancy BMI of about 1 kilogram per meter squared, the relative risk goes up by 1.06. So by the time you get up to BMIs of in the mid-30s and 40s, this is not a trivial figure at all. What about the risk of preeclampsia and metabolic syndrome? So O'Brien et al. in 2003 actually performed a systematic review, which interestingly hasn't been replicated since. And it shows that the risk of preeclampsia doubled with each increase in 5 to 7 kilograms per meter squared in pre-pregnancy BMI. And in this systematic review, various confounders such as pre-existing chronic hypertension, pre-existing diabetes, and multiple gestations were excluded. What about the risk of preterm birth, which is defined as birth at less than 37 weeks of gestation? So again, Chatsi used that same cohort, that we discussed a couple of slides ago in 2009, and it was found that the relative risk factor, relative risk preterm birth was 2.93 in people with the metabolic syndrome. And this was found to be particularly high in women who actually needed an induction of labor or earlier scheduled C-sections earlier than at 37 weeks. And the relative risk actually went up to 5.13 that these particular individuals had a metabolic syndrome. The relative risk was 2.32 for the patients with elevated blood pressure pre-pregnancy. And again, at the bottom there, I've listed the relative risk, for each increase in 10 millimeters of mercury of diastolic blood pressure, the risk went up by 29%. And it was 19% for each elevated LDL over HDL ratio by 1 unit. We would all know this paper very well. Boonsmer et al. In 2006 published a meta-analysis which looked at the pregnancy outcomes for women with PCOS, and the numbers were fairly substantial. I looked at 720 PCOS pregnancies and more than 4,500 controls. And I've listed the relative risks there, that certainly for GDM it was up to about 3.0, gestational hypertension was 3.67, preeclampsia wasn't actually that far behind at 3.47, and preterm birth 1.75, and the NICU admission was 2.31, and any perinatal mortality of any cause was actually quite high at 3.07. Okay, so at this point in time, I just want to spend a bit of time talking about dyslipidemia in pregnancy, because we all very experienced with looking after hypertension, after diabetes in pregnancy, but dyslipidemia is something that obviously exists as part of the metabolic syndrome, but we may not necessarily pay very much attention to it because it's something that kind of, I guess we don't tend to think about so much because we don't see the direct effects as much as the hypertension and diabetes that I was talking about. So I want to just spend a couple of minutes talking about the data that we have about dyslipidemia in pregnancy. So pregnancy, I guess, represents a unique opportunity for the detection of subclinical dyslipidemia. Again, a lot of patients may not necessarily have had a lipid profile checked, and they may have had it checked just for some reason leading up to a pregnancy, either by the general practitioners or, again, as I've alluded to, if they come to you for their annual visits, often if they're asking for a routine blood test, it might be that lipids may have been thrown in together with it. So what we need to know is that in normal gestation, like in normal pregnancy, we see an increase in lipid production to foster healthy fetal development. But what happens when this increase in lipid production becomes a bit too much, or people have pre-existing lipid abnormalities? So there's a lot of evidence that's emerging that the presence in pre-pregnancy and early gestation of particularly for atherogenic dyslipidemia increases the risk of adverse pregnancy outcomes, as well as increasing cardiovascular risk later in life. And the particularly atherogenic lipid profile that I'm talking about is what we exactly see in the metabolic syndrome, like where we see people with the elevated triglyceride levels and reduction in HDL cholesterol levels. And if you have the double a combination of this, people particularly atherogenic. So what is the data on dyslipidemia and the risk of preterm birth? So there was a study, a very acutely termed the ABCD study, published in 2012, which revealed that the patients with elevated LDL and HDL ratios, this is associated with an increase in preterm birth and cardiovascular risk later in life. And then in the same year, another set of authors showed that increase in triglyceride levels in the first trimester are independently associated with gestational hypertension, preeclampsia, and larger gestational age in preterm deliveries. And then the Cardia study, which was actually published a year after that, showed a U-shaped relationship between the pre-pregnancy total cholesterol levels and the risk of preterm birth. And it showed that people with very, very low total cholesterol levels actually had increased rates of IUGR in preterm birth. And that's not surprising because, as I alluded to, cholesterol is actually an important requirement for fetal development. But on the converse, the people with particularly elevated total cholesterol levels were associated with increased risk of preterm birth and increased risk of cardiovascular later on in life. So basically all of these papers published in fairly close proximity to one another over 18-month period all showed a very similar kind of thing to what happens to individuals with this kind of lipid profile. So what about the risk of preeclampsia with dyslipidemia? So a number of papers show that, again, patients with elevated triglyceride levels and reduction in HDL cholesterol levels, these 4 papers independently showed that there was an increased risk of preeclampsia in these women. And the authors in the 2013 paper showed that the preeclamptic patients actually also, at the time of labor and delivery, also had significantly elevated lipoprotein A levels. And lipoprotein A is actually one of the key drivers of elevated triglyceride levels in pregnancy. So these associations are fairly well validated now. What about the risk of diabetes with dyslipidemia? So as we all know, people with pre-existing type 2 diabetes tend to, again, have this lipid profile where they have elevated triglyceride and a reduction in HDL cholesterol levels. And then a couple of papers in the last few years have shown that obese women with BMI of more than 30 have, again, almost all of them actually by default have increased triglyceride levels and reduction in HDL cholesterol levels. And then a number of papers in the last few years have shown that the infants born to obese mothers themselves actually have an increased risk of coronary cardiovascular disease later in life. So what about the use of lipid-lowering agents in pregnancy? So as we all know, women tend to not like taking medications in pregnancy because they're always concerned about the effects on the baby. And so at this point in time, I want to highlight what are the things that we could potentially use if somebody has particularly deranged lipid profiles, and what are some of the things that we can't use. So statins, as a rule, we don't use. And the only exception to that rule is I've looked after people with familial hypercholesterolemia or hypertriglyceridemia before who has had recurrent cardiovascular events at an early age, and I looked after a couple of women early this year who got pregnant, having experienced a couple of myocardial infarctions, in recent years. And for these women, what we did was that we withheld the statins over the first trimester of pregnancy, but then we used it in the second and third trimesters because these people had stents, and there was a concern that if we didn't put them back on the statins, then the stents may occlude, and which would then cause other problems. But the other things that I've listed here we can use in pregnancy, like omega-free fatty acids, have been shown to reduce triglyceride levels and are safe in pregnancy. Nicotinic acid is something that we could use, but it tends to cause a lot of flushing. And it can actually elevate blood glucose levels, so we typically don't like using that in diabetics. And fibrates, in general terms, are not particularly very well studied, but a number of case reports have been published for patients who used it, and there so far has not been any adverse events reported with fibrates. So what about the effects of alcoholic fatty liver disease on pregnancy? So there was a very recent paper published early this year by Hagström from Scandinavia, which showed that 110 patients with alcoholic fatty liver disease, and these are the relative risk factors for these kind of things occurring, like 2.78 for gestational diabetes, 1.95 for preeclampsia, and 2.5 for preterm birth, just to list a few. Okay. So what about the effects of intervention on maternal weight? So probably the best known meta-analysis for this was published by Thangaratnam in 2012, which showed that basically, these authors looked at the 3 categories of interventions being diet, physical activity, and mixed approach. And I've summarized the main findings here, that overall, a reduction of 1.42 kilograms in gestational weight gain within the intervention occurred as compared to control. And it seems that the dietary interventions were actually the most powerful in terms of reducing maternal gestational weight gain. And with these interventions, there were relative risk reduction in preeclampsia and shoulder dystocia. What about the effects of physical activity and the risk of GDM? So surprisingly, there's actually not that much data in this area in the literature, but Liu et al. In 2008 showed that women who became physically active through brisk walking during pregnancy had significantly lower adjusted odds ratio of developing gestational diabetes compared to those who remained inactive during pregnancy. And there was a paper published early this year which showed that the maternal plasma C-reactive protein levels were significantly high in inactive obese women compared to active obese women. So again, this gave us evidence that the physical activity is likely to of help. So I guess in the last few minutes, I want to just discuss why is actually all this important, and a lot of this is to do with fetal intrauterine fetal programming. Like we try to set things up better for the next generation, by improving the health, the metabolic health of mothers who are pregnant. So I've summarized some key points here. So basically, a number of epidemiological studies have shown that the children of obese mothers who are at the highest risk of becoming obese themselves are the ones born to obese mothers, okay? And the paper in 2004 by Whitaker showed that even at age 2 to 4, 24.1% of children were obese. And these are the children born to mothers who themselves were obese. And the rate of obesity was much lower compared to the children born to mothers of normal weight. It was only 9%. And a couple of these papers have also shown that when they measured the metabolic parameters of children at age 11, again, the ones born to obese mothers have significantly elevated glucose levels, insulin resistance, and lipid levels compared to ones who were born to mothers of normal weight. And there was a very elegant paper in 2011 which showed that the maternal weight gain and increased BMI in between consecutive pregnancies increased the risk of obesity in the second child compared to the first child, okay? So that's why it's important for us, like whenever we look after these women, to make sure that they try to get back to the pre-pregnancy weight as quickly as possible before they attempt the next pregnancy. So what are some of the proposed fetal programming mechanisms? So I'll just kind of describe them in brief here, like, because this is kind of an interesting area of research at the moment. So the first one is that a couple of authors have proposed that maternal obesity is associated with elevated corticosteroid levels, which which then alters the fetal HPA axis development, and this in turn kind of increases the metabolic syndrome in the offspring. Another second proposal, which was kind of proposed last year, was that basically, babies who are in the wombs of the mothers with metabolic syndrome and obesity, like there tends to be a programming towards increase in orexigenic drive versus anorexic drive in the hypothalamic appetite centers when these babies are still developing, and so therefore when they're born, these program offspring will have much more food intake and increased weight. The third proposed mechanism, proposed in 2006, was that maternal obesity increased the maternal reactive oxidative stress markers, and this actually alters the fetal mitochondrial integrity and increase in neonatal reactive oxidative species, which then in turn promotes the endothelial dysfunction even from an early age. And last but not least, the fourth and final proposed mechanism is that the high caloric diets and maternal obesity affects DNA methylation, which in turn results in epigenetic changes, which increases the risk of cardiovascular risk for the offspring. So what is the current research focus? So we had a talk this morning about bariatric surgery, and so certainly a lot more women are getting bariatric surgery, either through the Roux-en-Y gastric bypass or the gastric sleeves. And again, we're waiting for more data on this, but back in 2006, a Scandinavian group showed that there was a reduction in the rate of obesity in the offspring born to mother status post-gastric bypass surgery. But just bear in mind that women who undergo gastric bypass surgery, they potentially at increased risk of various maternal complications such as malabsorption, osteoporosis, and various things in the future. And these days, more and more gastric sleeves are being done, and so it'll be interesting to see what the data shows for that. Is there a role for vitamin D supplementation to reduce metabolic syndrome? The jury is still out on this one. A lot of authors have proposed that giving extra vitamin D supplementation seems to help, but as yet the jury is still out, and there's a couple more randomized control trials which has to come out first, and at the moment it's not recommended to be done as part of routine. Does omega-3 fatty acid supplementation help? Again, you know, there's not, the data is fairly scanty on this, and I think much more data needs to be released before we start doing these things regularly. And last but not least, in the last few seconds, I just want to kind of talk about the probiotic supplementation, the role of this, because and this is a very area of hot research focus at the moment. And for those of you who came to my talk, other talk this morning, I just want to kind of quickly highlight what the gut microbiome does to metabolic changes. So a number of groups have demonstrated a role for gut microbiota in driving metabolic disease and inflammation, weight gain, and reduced insulin sensitivity. And particularly, there was a landmark paper published last year by Simon et al., which showed that probiotics in the form of lactobacillus and bifidobacterium have been shown to improve insulin sensitivity in non-pregnant patients. And so, you know, a few years ago, for those of you who don't know, like there were a couple of papers published by the NAMI group in Scandinavia, which showed that the use of probiotics in early pregnancy seems to reduce the risk of GDM. And right now, there was a large randomized control study being done in Australia to examine if the probiotics can be used to prevent GDM in the overweight or obese. So I think we need to watch this space, because this is an area of a lot of research focus at the moment. And I want to again thank you all for your patience for listening to my talk, and I look forward to talking to you more over these next couple of days. Thank you.